Very good morning to you all. Today, I am going to demonstrate a simple intraoperative technique to prevent varus collapse in comminuted four-part proximal humerus fracture or a fracture with significant osteoporosis. Here is a 48-year-old male presented with seizures. He is a known case of cavernous venous thrombosis. And you can see there is four-part fracture dislocation, which is posterior fracture dislocation. And you can see coronal and axial sections. You have GT fracture, you have LT fracture, and you have anatomical neck. And conventional beach chair position is taken by draping both the sides. The most important first step is to secure the tuberosities, LT as well as GT, and then head is being reduced with a shank spin in this case from posterior to glenoid fossa. That is after reduction. You can see medial comminution as well. After fixing the plate, you can as well see the medial comminution. I'm trying to push the shaft medially so that it supports the head. So that is after completion of fixation. And this is known as medialization, wherein I use locking screws and maintain a gap between the plate and the bone, which can as well go up to 1.5 centimeters also. And securing the tuberosities to the plate is very, very important. And you can see after reconstruction on right side, the gap between the plate and the shaft as well as left side, and you can see the medial combination in both the sides. This is after 6 months post-op. You have got good abduction on right side, but not that much on left side. It is because you can see there is a slipping of tuberosity underneath the plate, but by the time of 1.5 year follow-up, you can see full abduction positive and full range of movement, and the patient is doing all his daily activities, and you can see how much abduction is possible uh, on both the sides. And it is pain-free, and there is no avascular necrosis even on a X-ray on both sides. So proximal humerus fractures most commonly fail in varus. The incidence is as high as 16.3%. In various other studies, it is more. Intraoperative techniques to prevent varus is acceptable reduction, counteracting the rotator cuff using suture anchors, and medialization of shaft and calcar screw. If you rotator cuff pull can actually result in varus forces when the shaft is lateralized, and it is much more common when there is a comminution on the medial side or in severe osteoporosis, which results in varus collapse of the fracture. And so that is the critical area, which can be actually addressed by reinforcing the medial buttress. And most of these fractures, in spite of angular stable devices, it goes into varus collapse. This is, you can see this particular picture where a cone ice cream with a bigger ice ball can as well be retained when the rim is intact. But when the rim is broken and it's off the track, then obviously it causes, the ball to fall down. But when you actually centralize it to hold the cream ball, it is possible. This is exactly is the principle of medializing it. And so on a medialized shaft, where the space between the plate and the bone is maintained, these varus forces resultant of rotator cuff pull are converted to compression forces at the fracture site. And you can see how it heals. This is a picture which shows there is a medial comminution, and that is the supporting area and the unsupported area of the head. So that is the supporting column. And when you put a weight or varus pull, it actually collapses. But when you medialize the shaft, the lever arm of deforming forces comes down and the head support increases, by which varus collapse is prevented. This is a case of 45-year-old female, medialize the shaft, and that is after the fracture healing, and you can see full range of movement. 80-year-old female, significant osteoporosis, medializing the shaft, fracture has nicely healed with a very good functional outcome. And another 65-year-old female, medial comminution. So, sequence of X-rays, gradually fracture is healing and the corticalization is also happening on the medial side. So, this is just a pictorial uh, diagram to show how exactly this happens. So, here there is four-part fracture. Once you reduce the fracture and fix it up with a angular stable plate, you have got like Philos plate. This rotator cuff pull is as significant as 340 newtons every time a patient moves, and that causes varus collapse, especially when you have a combination on the medial side because that is unsupported. But how to address this particular problem? So the first and foremost important thing is these varus forces resultant of rotator cuff are to be neutralized or contracted by securing them with a suture onto the plate. And this actually acts like a tension band. But when there is a medial cortical buttress which is intact, where it acts like a compression forces, like a olecranon tension band principle. But when you have comminution, this principle doesn't work. And that's when you medialize the shaft to continue to have the advantage of tension band principle working on the underneath the head. And at the same time, it supports the head. So this is our publication in Journal of Shoulder and Elbow Surgery. That is for your reference. And take home is rotator cuff pull can only be counteracted by securing the tuberosities to the implant. Medial buttress is important to give tension band effect and to support the head. Medialization decreases lever arm of deforming forces, supports the head, and increases the effectiveness of tension band principle. Simple intraoperative technique and doesn't alter the function of shoulder as tuberosity anatomy is very well preserved. Thank you very much for patient hearing.